Everybody. I'll just start here. So thank you for that lovely introduction. I finished my PhD actually at the end of 2022. 2023 was a blip in my consciousness, and I'm still actually recovering from that. It's a big undertaking, well worth it if you're thinking about it, but it is a big undertaking. So this presentation today is really an opportunity to share some of the research that I dug into related to the evidence behind how we deliver services to our school-age children with more significant disabilities, and specifically CP, GMFCS 3 to 5. It's a topic that's quite close to my heart. As a physio working in early intervention, or child development services, you have the privilege of building really close relationships with families you're working with. You have regular visits in their homes for around 5 years. And then you hand them over to education and shut the door and hope that you've done enough to get them through the next leg of the journey. And you do this because you know that even though they've been given AWS funding, which means they are part of about the top 1% of the school population with the most significant disabilities, and AWS funding gives them access to specialist services like physio and additional teacher aid support in the classroom, it's going to be a tough transition from the way things are done in early intervention services or child development services through the health services to the way things are done in school-based services through the Ministry of Education. Health services, for the most part, follows a more traditional therapy approach. It's family-centered care. There's a lot of one-on-one interaction, a lot of hands-on therapy, either in the clinic or in parents' homes, children's homes. And Ministry of Education really prioritizes access to the curriculum through a consultative model of care, and there's a steep drop-off in parent contact with the therapy team. As one of the parents in my research study noted, I think it was worse at that 5-year-old stage when they started school. I mean, I just remember back then feeling like I'd had a safety net pulled out from under us and we were just left. So this is a direct quote from the transcript of an interview with one of the parents in my study that formed part of the larger study for my PhD. And it really captures the experience of transitioning out of the health services and into education services. And I think it's important to say two things here. Firstly, I'm starting with this quote because it so beautifully captures the sentiment and the experience of many parents in my own research study, but it also captures the sentiment and experience of parents across the globe and across time, as I'll show you in the research we're going to look at today. And secondly, it's important to say that my PhD topic had nothing to do with school-based therapy. As Donna said, I was looking to explore how we could use technology to support parents at home with their therapy home programs for their children with cerebral palsy who did happen to be school age. But I was looking at therapy at home. And when I started interviewing parents, so much of the conversation was about how parents were thinking, feeling, and doing the therapy home program in relation to the frustrations that they were having at school with their kids' therapy programs there. So therapy in schools became an unexpected major theme in my research, and I spent a fair amount of time really trying to understand where the policies and the thinking relating to therapy in schools was driven from. And so what we're going to do is start with a policy. It's a report that was written around the policy. The report was written 20 years ago, looking at the impact of New Zealand's approach to disability in schools, and that policy was called Special Education 2000. So Special Education 2000 was a significant policy initiative implemented in New Zealand around 1996. It was meant to support children in schools and facilitate collaborative partnership between schools, families, communities, and support agencies, which sounds really lovely. The report provided an extensive review of the Special Education 2000 policy and raised concerns about the blurred boundaries in responsibility between education and health when children with physical disabilities are managed through education services. So the report took in more than 1,000 submissions made within 2 months of the consultation starting, and it included a wide cross-section of New Zealand society. It included site visits to schools around the country, public meetings, meetings with relevant organizations and interest groups, and it drew on all available research, official papers, guidelines, statistical data, and international research and policies as well. And what they found was that there was a fragmentation of services, gaps in accountability between education and health, inequalities of resourcing and opportunities for students with special needs, depending on where they were and who was assessing them, as well as really unrealistic caseloads, which were made worse for therapists who had to travel between schools. And because the support services like the therapists and the teacher aides were really attached to the children and not attached to the school, they found that there was it led to kind of many therapists leaving when the child left, or many experienced staff leaving. So there was this loss of expertise that wasn't easy to replace, because obviously those people moved on to other things. And they also noted that professional development was patchy, and it was often really focused more on teaching the therapist how to adhere to the policies rather than on developing therapy skills specifically. And of course, there was this constant reinvention of this wheel in Ministry of Education. So it was a bit of a shock for me to see that the frustration parents in my study were expressing to me with school holding this primary focus on education goals was strikingly similar to the frustrations parents expressed in this review and some that followed afterwards, despite calls for change that is really now 20 years old. So we're going to just take a few excerpts out of these studies. What this first one found that I was just talking about now was some of the things they noted parents and schools were saying was that workloads were too high to provide meaningful services to many children at school, and there was this inability to meet reasonable needs. It had become fragmented, distance from the people in the schools and the parents who needed to feel like it was working for them. So there was this real disconnect between schools and parents. And many parents with students with special needs felt like they had no option but to become fighters to try and get the services they needed for their children. So then this next report from 2007 was actually produced by Ministry of Education. So it had a slightly different flavor. But they also noted that parents had to do considerable liaison work between schools and outside services. Again, parents were quite disconnected from the school staff. And what they did find was that settings that still had therapists on site in the schools were able to maintain high levels of contact with families at school and at home, which is what we were going for. And they compared this to schools that had what they called itinerant therapists. I think that's such a funny word. So the itinerant therapists are therapists that are moving between places. They don't actually belong to a school. And those therapists were having a lot more trouble maintaining that contact and relationship with families at home. And some parents and teachers were actually questioning whether there was an emphasis on learning outcomes that was detrimental to the children's physical outcomes. So when the authors analysed this, they made some suggestions, and their suggestions were really that the staff and therapists actually just needed more time and support to ensure that there was a shared understanding of what the overall goals of therapy in schools was, and that's really to support access to the curriculum. And then this last one over here in 2011 was obviously not published by MOE, because you can see by the name that it's got a bit of a negative swing to it. So they noted that the SE 2000 policy represented the antithesis of inclusive education, and it was not a needs-based way of working with children with special needs. And this is where it becomes really interesting, is that there was a dearth of research into the practical outcomes for children of this policy, despite the emphasis on evidence-based practice that everybody bangs on about. And there was no evidence to show which children had benefited, how many had benefited, and in what ways they had benefited. So they specifically noted that therapy services were dictated by management or policy decisions rather than professional analysis and decision making. And that's an important point, because that theme carries throughout. So Barbara Perry is a teacher. She's a school principal, a disability studies lecturer, and a parent of a now adult son with cerebral palsy. She captured her experiences of accessing mainstream schooling. She wrote this paper in 2017, but her son started school just after the SE 2000 policy was put in place. So she tells the story of her son Joshua, who started school in 1997. The SE policy was started in 1996. And her son required assistance with personal cares and eating. He needed a wheelchair for mobility, and he was classified as having very high needs spastic quadriplegia. And she noted that physio, speech, and occupational therapy were either provided spasmodically or not at all, depending on the location of the school and his age. And as he got older, these needs didn't seem to matter at all, despite the fact that his bones had begun to stiffen, and his legs, and at times he suffered back pain. In the mainstream, this was simply not a priority. So that's a direct quote from the article. For those of you who are familiar with this, with the kind of therapies that most children have access to at school, you'll recognize then that in the 20 years plus since her son with spastic quadriplegia started school, her words reflect a system that doesn't really appear to have changed, despite the best of intentions and beautifully well-worded policies. And certainly for the parents that were in my study who were aged between 5 and 12, where they were really at the start of their school career, nothing much seems to have changed for them either. And in my interview with parents, they describe a context of continued fragmentation of services, of infrequent visits, a high turnover of therapists who didn't know their children, frustrations with systems that were not able to support them with their school-age child, of having to fight to get their child's needs met, and of not being listened to by school staff and by therapists. So as children reach school age across different continents, the experience of parents seems persistently similar, despite differences in policies and funding for health and education in different countries. So qualitative studies exploring the experience of parents of school-age children with disabilities in Ireland, in South Africa, in Canada, in United Kingdom, in Switzerland, in Norway. All of these gone too fast, sorry. All of these qualitative research studies really show the same thing. I'm just going to pop all those down again. They describe parents who are exhausted by having to fight to get their child's needs met, of having to bridge a health and school system that doesn't communicate with them, of carrying the responsibility for teaching school staff who are untrained, of feeling lucky when they do get support for their child in a school system that is school-centered rather than family-centered. And in addition, parents describe a lack of relationship with therapists in schools, the additional burden of having to physically support their own child at school when services are not provided, despite policies of inclusion. And if this is starting to sound repetitive, it is because it's been repeated for so many years by so many parents in so many places. But the system of accessing the curriculum as a primary aim for school-age children seems to be persistently reinforced. So this was a study done in 2021 in America, and they surveyed 207 parents across the USA. And they found families receiving only school-based therapy services were twice as likely to report low satisfaction retrospectively with the services than those that had received both school-based and family outpatient services. It was like 73% to 29% respectively, which is quite significant. And at this point, you might be thinking, well, maybe the parents are struggling with their kids transitioning to schools. It's quite hard to go from this approach where you're having the therapist supporting your child and doing actual therapy to going to a school-based model where they're teaching children to be independent and access the curriculum. With therapy in schools as a service seen across so many different countries, there must be good evidence to support it, right? Right? Well, I don't know. So when I started digging into the research, I wanted to know, what's the evidence for a consultative model of care in CP? What sort of value was derived from a model of care that separated school-based services from health-based services? And I was really surprised to find that pretty much all of the research around school-based therapy was super focused on how therapists adhere to recommended theoretically based guidelines that prioritize children in the school environment accessing the curriculum. So whilst there was a few publications showing therapy in schools can be effective in achieving school-related goals, there is an absence of evidence to show that school therapy or school-related goals is effective in meeting the broader goals of parents and children's preferred outcomes over the long term. So we'll start with this 2014 article that represents the evidence-based literature around therapy in schools. It's a look at school-based therapies working in the USA. I couldn't find a similar equivalent to New Zealand, but it really illustrates the points that I've touched on with the New Zealand-based reviews and articles as well. And this was an analysis of a large number of therapists. 561 school-based therapists responded to a survey. And the study from analyzing the survey concluded that therapists were not practicing to the extent they thought ideal in many areas, they being the authors of this paper, with Susan Efkin being quite a key player in this area of academics or research. So therapists thought ideal practice was the heavy emphasis on direct hands-on intervention rather than indirect service provision. Hands-on intervention has become a bit of a swear word. This preponderance of hands-on intervention, that's their words, is not necessarily best school-based practice. And really, therapists were obviously in need of being remediated themselves. That's my words. Therapists needed further education to help them recognize best practice for school therapy delivery. They needed help to recognize that best practice for school therapy delivery meant consultative, hands-off, and definitely not in a therapy or clinical space, which they called isolated services. So I had a look through their references in this paper to try and understand where they were pulling these very strong recommendations and critiques from. And I was a little disheartened or surprised to see that the evidence recommendations are really based on policies. In America, it's called IDEA. Ours would have been the SE 2000, I guess, and theories. Because in 2014, these authors noted an absence of strong empirical research, but that didn't stop them from pushing the agenda. So in 2020, Efkin again co-authored another paper looking at how school-based therapists were doing school-based therapy. And this time they got 410 responses to the survey they sent out, and it represented most of the states. And they still found this persistently annoying gap between how therapists were practicing and policy ideals of school-based therapies. What they found was that kids were more likely to get the less than ideal hands-on therapy if the children were less disabled, and they attributed that to the fact that children who are more disabled, the therapy pretty much entails managing equipment and classroom stuff. So if the children had some capacity to develop skills and quality of movement and therapists had to put their hands on them, that was less than ideal. Employment contracts also dictated children who got more therapy because, again, the administrators may also not fully understand that school-based therapy practices and how to write contracts for that support embedding services. So it's another group that really needs education on policies and theories because there's no evidence base to educate them on, really. And family preferences, because parents' expectations for isolated therapy services were barriers to providing services in students' natural settings. Parents' opinions differ on the emphasis of therapies because their parents thought that their children should be getting therapy in school by the therapists, and they didn't understand that therapy in school by the therapist was not hands-on and was predominantly consultative. So this is kind of what we're envisioning this integrated therapy approach looks like. It's fun. It's in a super fun environment. Children are hanging out with their peers, and it might look like a great place to do therapy on the surface, but it could equally be seen as an imposition and an interruption of peer-to-peer play, where you're the adult interrupting some natural interactions between the children. So what exactly is ideal therapy in schools, and should it be mandated is the question that I put to you. So again, more recently, Efkin and co-authored this paper along with Lisa Chiralo, who's also a big player in this area of school-based therapy research, and Robert Palisano, who is editor actually of physical and occupational therapy in pediatrics. So these are really big players in sort of the school-based therapy research and in cerebral palsy research as well. And this paper was looking at service delivery and relating it to outcomes, which I thought would be helpful. And they examined the goals and the subsequent service delivery and outcomes of 109 very experienced school-based therapists. That's their definition. Children who had participation-based goals, they found received more therapy than those who didn't. But regardless of if they had participation-based goals or the non-participation-based goals, the students equally achieved their goals, and there was actually no difference on any other measure. So the obvious conclusion then was that therapists should therefore do more participation-based goals because, well, policies and theories and all of that. And so just in case you're wondering, non-participation-based goals included things like quality of skill performance, whereas participation-based goals might include things like transfers. So these leading experts noted that the service delivery model in schools was based on professional and state guidelines, which we've kind of seen all along, but they also made this strong statement that they hadn't made in the 2014 article, which was that these guidelines on how to do therapy in schools were more effective, or at least as effective, as therapy in isolated environments, in other words, traditional therapy, which I thought was a big step forward. It's a strong statement, except that the articles they're using to back up the statement are from 2004 and 1995, long before 2014. So I'm not sure how they suddenly dredged up these articles that they'd missed in 2014. But I did what you would do as a PhD student, is I also hunted them down and I read them, and here's what they said. So at the top is the 2021 article that we're referencing here by our leaders in the field, and the two articles that they use to support them are the 2004 and the 1995. So the 2004 article was a questionnaire, again, returned by 107 therapists, showing that the majority of kids received therapy services in isolated settings at your clinic room, and there was no difference in outcomes compared to those who received therapy in integrated settings. And they concluded that physio and occupational therapists provide services in both settings, often using both approaches based on the treatment objective, the child, and the environmental variables. They said, we found no evidence that an integrated model is more effective than an isolated approach to intervention. So basically what they're saying is that when therapists are making decisions based on their own clinical reasoning, children are showing outcomes regardless of where they're being seen, which is interesting. And then there was this 1995 article, which was also super interesting. It was based on a total number of 3 children, barely even a pilot study. In the study, they did a baseline where they videoed the kids walking, and then they did 2 sessions per day for about 10 days, depending on the child. So it was 1 session in the clinic or the isolated environment and 1 session in the integrated environment, and they randomly chose which one went first. And then they videoed the children doing the walking and their posture, and they analyzed the videos. And what they found was that the videos looked better. The children were showing better posture and gait in the natural education setting. And it was a superior performance to that was happening in the clinic with these 3 children. And not to state the obvious, but a study of 3 children receiving 2 different therapy sessions on the same day, every day, for a total of 10 days is hardly sufficient evidence to support mandated policies of how and where therapy should be delivered. Anywho, on the upside, the study also gave me one more paper that I thought might possibly shift my skepticism. And this was a study from way back 1989 that they also didn't manage to dredge up for the 2014 article that we started with. So I dug it out. And again, this article showed the same thing, no significant difference in outcomes between kids who had therapy in the therapy room versus the classroom. But they did notice that staff favored therapists being in the classroom. And when you ask the question why, I delved back into the article, and it very nicely there described for me that teachers preferred the physio or OT in the classroom because they could facilitate the academics of the children. In other words, they served as expensive and highly qualified teacher aides. That's my interpretation. So from my perspective, reference mining and searching for school-based articles in New Zealand and internationally has yielded very little in the way of convincing evidence to support policies that insist school governing bodies, parents, and therapists are all wrong in their perception and expectation of what therapy services should provide. They have had this constant battle of trying to convince parents and therapists that school therapy must be integrated into the school, a consultative model, and hands-off. I'd be very happy for anyone to share any research that I've missed that may show something that really supports this view. The articles that I've found overwhelmingly focus on how therapists are adhering to the policy and guideline requirements, and it tends to be poorly. However, it wasn't all bad because I did find one article in 2022 that actually suggested a complete paradigm shift. So this article suggested a change in paradigm, which was a shift back to old school thinking where therapists actually did therapy. They noted that in the past, the school district provided professional development during each school year that was more closely aligned with the needs of education, but not necessarily relevant to the related service providers. Think back to the article we started with that was written in 2000 that said exactly the same thing. In New Zealand, this is American-based. So of specific note was their takeaway that they had been underdosing strength interventions used in the school setting because when they were doing strength with the kids, strength training, they upped the intensity, they were doing it in the therapy room or in the school gym, kids had gains in both health and participation outcomes. So they concluded that physical therapy services should be provided in school settings and should not be limited to established paradigms of traditional service delivery, where traditional service delivery has now done the shift being the hands-off consultative integrated model. It's really funny how the pendulum swings. So from my perspective, I think that there is value in both approaches that address participation in an integrated environment and those that address more body structure and function type health goals in a isolated environment or in the therapy room. And I think the challenge is knowing when to do what. And really, that's what therapists are supposed to be trained to do, is be able to decide where it's best to be doing the therapy for that particular child and what the best focus is. So should we continue to accept mandates of how we should be supporting kids with CP in schools when there's obviously a lot of stress, heartache, and disagreement from the parents who struggle with an education-based model that is more concerned with accessing the curriculum than the rehabilitation of their children, despite so little evidence? Really, what I found in summary is that there was no evidence, I put limited evidence, but that's being generous. There was no evidence to support the separation of health and education in managing children with cerebral palsy. There's no evidence to support push-in services into the classroom versus therapy services in a therapy room as being superior. And there's no evidence to support a consultative model for school-age children. However, there is a significant volume of qualitative research showing parents and therapists struggle with the theoretical policy-based requirements of school-based therapies that prioritize accessing the curriculum and disregard therapists' clinical decision-making and parents' goals and aspirations for their children. And as was summed up so beautifully by one of the parents in my study, I still can't for the life of me understand why the Ministry of Education does physiotherapy. I'd be pretty upset if my kids had a teacher who was a nurse. Why should Ministry of Education provide physio? It's kind of not their gig. It's not what they're good at, you know. Really, it's an odd system. So from my perspective, children with CP do need more attention to their physical health and well-being than their physically able peers. It's just a given. And I think we can do better with our school-age kids. I think they deserve better. And in those early school years where they're undergoing rapid growth and physical changes, the research tells us that between 7 to 8 years of age, they're going to be at increased risk for orthopedic complications that require significant surgeries. And we're talking here about breaking bones and sticking metal pins and plates in the hips of 7-year-olds. Really, at an age that the research shows that children with cerebral palsy are losing skills that they've worked so hard to achieve in the early intervention years. Walkers are becoming permanent wheelchair users and there's increasing pain and deformity. These are the years when therapy services are pulled back and parents are left to figure things out on their own. And the reason this happens is because policy dictates that therapy in school should be managed by an education service that has limited investment or experience in health and disability. It is an odd system, really it is.
Wow, thank you very much, Mindy. I'm sure that's got lots of people thinking lots of interesting thoughts. What I'm going to do is I'm quickly going to show our questions for our next session where we're going to come back together. And while I'm doing that, if anyone's got any questions they want to pop into the chat or to ask Mindy, I will just share. There we go. Here we go. So our questions for next time, we're going to come back in a month and discuss these in more depth. And we will post these up onto the website as well, and also a link to the video so you can re-watch it. So looking at utilising local therapy and local agreements, how can we do a better job of supporting healthy growing bodies, and what is worth keeping, and what do we need to contest with our current service provision as well. So the information for next time is there, and we will send out a flyer as well. There's also information about our mailing list to make sure that you're getting information about our sessions coming up. And then what I'm going to do is I'm actually going to stop the share, and as I said, open it up to questions. I'm aware that people may need to leave, which is why I wanted to cover that. And I can see there's a few popping up into the chat. Cool. So, that's great. There's some, thanks, Mindy's questioning about where it's available to get Mindy's PhD. So it's in the Otago repository.
I'll just say, Donna, regarding that this was a section of a much, much larger PhD. So
Yes.
there's a chapter that specifically around the qualitative analysis of parents' experiences with therapy home programs, and within that chapter, there's a section on school-based therapy.
And Mindy, did you mention you were looking at trying to get some of that viewpoint publicized, or
Yes.
obviously you're sharing it in terms of in this knowledge translation setting here. So yeah.
Yeah. So that is on my list of things to send to Fee to review. As my supervisor, it's been on my list for a few months, but it's coming, Fee. So trying to get this particular piece published will be my goal for the next couple of months. But yes. So for speech and language therapists, Emma, I would be happy to contribute something. I think there's a couple of things. There's this publication and that I'm going to try and get through, and I've put in an application for the Oz Academy. So I'm not sure how that conflicts, but certainly in the next couple of months I'll have some clarity on that, and I could just reach out to me. Yeah. Thanks, Bea.
Can I make a suggestion that if you're in a team with people, or some people haven't watched it today, that because it's been recorded, you watch it again in your team, so that when you come back next month, we can have a really robust discussion. Don will probably break us into little breakout rooms so we can discuss the 3 questions in groups together. As the lunch and learn is only a very short time, but some really good discussion can come out of this.
Yeah. So there were some of the parents in my study had moved from a traditional school to a more specialist school, and they definitely reported they were happier, but it wasn't a part of my research is to compare and contrast that. So statistically, it wasn't anything that was meaningful. It was just an experience of a parent. Yeah. But it was interesting to note that in the 2000 review, in the SE 2000 review, which was done in 2000, that they specifically noted that therapists who are integrated in the schools and attached to the schools had a better capacity to build relationships across school and home with families. I didn't, Fee. So Fee asked, did you come across a study comparing special schools with integrated school enrollment? No, I didn't. I would have liked to have seen a study like that. I really did try and look for studies that sort of had any kind of positive swing on outcomes for therapy in schools, and it was hard going. So if anybody has any, I would genuinely be interested to see them.
Have you seen Margaret Jones has just mentioned about some work done by Sarah Williams? I don't know if you came across that at all, Mindy.
I didn't. I'm going to go have a look at that. Thank you, Margaret. Yeah.
Oh, and I think Fee's popped a few comments in as well in terms of whether the plan was to move for more integrated.
I think that move to the integrated services is across the board in rehab, where you're kind of following a theoretical approach of doing therapy in the lived environment, and it was translated into the school environment as well. And as I said, there's certainly times and benefits of doing that, and it's important that we do eventually take our therapy out of the clinic and into integrated environments of lived experience. And when that happens and how that happens, I think is a clinical decision that shouldn't be mandated as a policy that overrides a huge set of very heterogeneous populations. So
yeah, I think especially like you're saying, if you're trying to look at person-centered and like everybody's different in where their setting is, and that's part of the clinical reasoning as well. Yeah.
And I mean, I thought that study was particularly interesting where therapists were choosing where to do the services and outcomes were equivalent, because I think it just speaks to the fact that that's what therapists are trained to do.
Cool. And then Fee's just mentioned as well that Sally Kidd's looking into transitioning in this New Zealand environment as well. So there'll be some more findings and development coming in that area as well.
Thanks, Mirren.
Okay, so once again, thank you very much to Mindy for presenting. It's fantastic to see so many of you here, and I'd really strongly encourage you to have a think about the questions, to look at joining us next month, and looking at how you can look at integrating that into your practice, or having further discussion on that as well. So as I said, there's the link there, and there are the questions there as well. So as I said, we will have this information on the flyer that comes out. What you might find is, if you've got some thoughts or questions now, jotting them down somewhere, so that when we come back in a month, you've got that opportunity to raise them and discuss as well. I'm sure we could be here for a lot longer, but very much aware that this is people's lunch times and squeezed in between juggling many things. So thank you very much, and I will end our session.
Thanks, Donna.